The next symposium explores integrated strategies for chronic disease management under the theme Enhancing NCD Care Across the Continuum. I cordially invite Professor Chamila Methananda and Dr. KVC Janaka to chair the session.
Good afternoon. The next symposium is on enhancing NCD care across the continuum. We'll be having 3 lectures. The first lecture is on individualizing glycemic goals and therapy in type 2 diabetes by Professor Tilak Veeraratne, MBBS, MD, FCCP, FRCP, FACP.
Good afternoon and thank you for your presence. Sorry about making a small change in the title slide. Goals have become targets because I am not a football player, I am a marksman. So, welcome to this session on individualizing glycemic targets and therapy in type 2 diabetes. During the next 20 minutes, I'll be talking to you to give a review for the rationale for advocating individualized glycemic targets and therapy for patients with type 2 diabetes. In doing so, I will take you through 5 of these subtopics just to find an answer why you should individualize glycemic targets and therapy for patients, and how the shift of guidelines from one size fits all became individualized therapy, and what parameters matter in the individualization of glycemic targets and therapy, and finally, to sum up with case scenarios and forecasting the future through the available evidence. I think all of you will agree with me. Among the many things that we know about type 2 diabetes, the most fascinating things about it to me is its heterogeneity. Even though we call it a one disease entity, it is widely heterogeneous. Attempts have been made to classify diabetes in the past. From type 1 to type 2 is the currently available classification. But we do know within this type 2, there's some type 1-like behaving, what sometimes called 1.5. But outside this type 2 also there are some guys like MODIs and all. So we don't know much about this heterogeneity. To answer this question, some researchers in the West have used a cluster classification, a clustering by selecting few major clinical and biochemical parameters, age, BMI, HbA1c, GAD antibody level, insulin resistance indices, and following them up and try to come up with a better understanding of this heterogeneity. And they came up with these 5 types of type 2 diabetes, all different from each other, so heterogeneous. So they seem like SED, SID, MOD, SERD and MAD. I'll tell you what these mean. They are not code names of a World War III or something, but they are useful for the application of and prediction of outcomes. That's what matters, we the clinicians, how we can predict this particular patient with diabetes might end up with early insulin requirement, and this patient might end up with early nephropathy, and that is what we as clinicians would know, and that is why this individualization is required. So this is what SED, SID, SERD, MOD, MAD means. Severe autoimmune diabetes, severe insulin-dependent diabetes, severe insulin resistant diabetes, mild insulin resistant with mild obesity related diabetes, mild adult related diabetes. So these are the 5 types within the so-called type 2 diabetes that we come across nowadays. The SED is early onset, lean, they have poor metabolic control from the beginning, they are insulin deficient and they are GAD positive. The SID, they have all the characteristics other than the GAD being negative. SIRD, they are insulin resistant but they are obese. But mind you, there are so many patients obese who are metabolically healthy. There's a category of obese who are metabolically healthy. But I used to call them, you are metabolically healthy but you are mechanically unhealthy, because what they develop is arthritis and so on and so forth, and then get the MARD. So these are the 5 major types. So if you can identify these 5 types and give individualized therapy for these, hopefully we can expect better clinical outcomes. So the parameters used so far are the age at diagnosis or age at the onset. I would call it age at diagnosis. We do not know really the onset was, it's at the diagnosis. The onset may have been really in utero. The BMI and the pathophysiology, IRO, IS. But these are the conventional parameters. With the advent of or the transformation of the glucose lowering guidelines over the last 3 decades, what you notice here, don't worry that you don't have to go through each and every letter because this is a crowded slide. Way back in 2000, we initiated all patients with type 2 diabetes, metformin, unless otherwise contraindicated though. But come 2025, we don't do that. The education is not that. You decide the first line therapy based on the comorbidity, whether you have established ACVD, whether you have a heart failure, whether you have some form of renal impairment. Then you have a specific therapy which is proven to reduce the progression or proven to reduce the mortality due to that particular disease. That's where the one-size-fits-all hypothesis has been changed with the addition of comorbidities and complications at the diagnosis. Therefore, with this approach, we clinicians have 5 phenotypes that was described in the cluster analysis by the researchers about 3 years ago. Even though it has not been come into guidelines as such, but as clinicians treating diabetes patients, we know these clusters do exist in the widely heterogeneous group of type 2 diabetes. So, this heterogeneous group, young, old, thin, obese, insulin resistant, insulin deficient, they need individualized care. If you treat them all alike, that's what we have been doing all this time. That's what we have not been able to show a drastic reduction in the mortality of patients with diabetes. Even though we can boast about advances in diabetes and treatment and so on and so forth, the fact is that the cardiovascular deaths due to diabetes, progression into renal disease due to diabetes, haven't been changed significantly over the past, at least up to a decade ago. Now we are seeing some change with the individualized approach. So the first part of this lecture is mainly on the glycemic targets. I'll talk about glycemic therapy in the next part. Individual glycemic targets in type 2 diabetes. We do know that glycemic status is currently measured not by just fasting blood glucose, by the glycated hemoglobin, and also not again by the home blood glucose monitoring alone, but we in Sri Lanka also now can boast that we do have continuous glucose monitoring in our country, at least in the private sector. So in that continuous glucose monitoring, which I will elaborate more in the next slide, we talk about time in range, we talk about time above range, and we talk about time below range. That's important for the patients to understand that you cannot be in one particular blood glucose level every time, because that's one of the main questions bothering them. Doctor, yesterday it was 110, today is 115. Why is this? And so it's a range, and you can go up and down within this range. So you don't have to go through the how frequently HbA1c is that, but just to make sure that the recommendation is at least 2 times a year. Even the newer guidelines on ADA says if the patient's HbA1c is stable, that is really relevant to a country like ours where the HbA1c test is quite expensive. But if the circumstances demand, it may be checked frequently than that. This slide summarizes the metrics of continuous glucose monitoring: ambulatory glucose profile, time in range, time below range, time above range. And to be optimal, we expect time in range to be at least 70% of the time. So 70% of the time is good, because as an academic ISO, we give a distinction when the 7 marks above 70. So if you can keep your time in range within 70% of the time, you are okay. Your HbA1c is going to be good within the optimal level. But for a patient who are high risk of hypoglycemia, if your time below range is more than 50% of the time, that is not good. I'll come to that later. So let's talk about the lessons that we have learned from the landmark clinical trials, controlled trials. You can forget about the DCCT at the top because it's type 1. And the next UKPDS, Accord, Advance and Verdit. What did it reveal? They revealed that microvascular complications can be reduced, not the CVD significantly. And Accord revealed that mortality is increased. But if you look at the second one with the graphs, that is more important. The UKPDS post-trial monitoring showed us the legacy effect that the early intensive control in younger patients had a benefit even after 2 decades. And the Accord showed us if you try to reduce in an elderly established patient with diabetes blood sugars too much early, too much soon after the diagnosis, you will end up with a high mortality. But Advance showed you can still reduce it, not at the beginning, toward the gradually, then only you get the benefit of glucose lowering in the elderly. So these are the lessons that we have learned. So lessons learned in the history often shapes our future. That's why we now do not go very hard on elderly when they are diagnosed, especially when they have established cardiovascular disease. So individualized based on the characteristics of patients with diabetes, not only the age, not only the BMI, others as well. Now these are the guidelines. A1C less than 7 for otherwise healthy people, but A1C is definitely different in different categories of patients. And A1C is also slightly different among the professional organizations, from ADA to AACE to ESAD. And so this also gives some ideas about the time in range target. More than 70% of the time, there's a high evidence grades for that. And the moderate evidence for older adults, the time in range should be 50%. So 50% times they can be out of range. But if you try to keep them 70% of the time within the range, they will end up with hypoglycemias. That's the lesson. So we'll take the younger patient, low risk. They need tighter target. They need early intensive control. Because we are hoping a legacy effect. In about 2 decades of follow-up, early tight control preserves beta cell function. There was an earlier theory that when the blood sugars are very high at the beginning, you need to give insulin to preserve, because there's a glucose toxicity and beta cell will not respond to secretagogues. You have to get the beta cell to rest and give exogenous insulin. but it is not much taken in the latter studies. And MACE reductions with early control is proven with the post-trial monitoring of UKPDS. For older frail patients with multimorbidity, of course, there are less stringent targets, 7.5 to 8.5, time in range more than 50% only, we don't expect again. And de-intensify. Now here, type 2 diabetes is a progressive disease. You need to keep on increasing, but there comes a time you have to de-intensify. So keep that in mind in managing older, frail patients with multimorbidity. So this slide summarizes, according to the stage of diabetes type 2, how the HbA1c is set, target is set for HbA1c. So I will skip because I have a 7.5 minutes for the going through the individualized glycemic therapy. I thought that is more important. So still it is a glucose-centric, but glucose-centric according to the patient's weight, hypoglycemia risk, and other factors. If they are non-obese and all that, you can go into other guidelines or other algorithms. So this is a comorbidity, so complications. This is the newer approach to patients with type 2 diabetes medication algorithm. You go by the complication of comorbidity-centric algorithm. The ACVD, they have a different pathway. If they have a CKD, they have a different pathway. And if they have a high prone to strokes or previous strokes, they have a different pathway and different agents. Let's look at the obesity-centric pathway. If the BMI is still 27 to 29, preferred one ideally is a GLP-1, but in our setup, it will be metformin to start with. And when they are in the range between 30 to 35, like you have the GLP-1 dual and triple, of course, when the BMI is very high, they should go for bariatric surgery because that is known to even cure them of diabetes. When it comes to secondary-centric, early CKD, in the sense the eGFR is between 90 to 60, the first line is SGLT2, along with AC and ARBs. And the moderate, again the first line is SGLT2, and advanced CKD, of course, it's a GLP-1 has a little nod more than the SGLT2. ACD-centric pathway, those with established cardiovascular disease, the main focus, if the heart failure is the main comorbidity, number needed to treat and the absolute risk reduction, SGLT2 comes high in the list next to the GLP-1s, and you can give combination therapy. You might wonder what happened to metformin, your good old friend. They do have remain the first line OHA for the most patients if they do not have any of those established ASCVD, CKD or heart failure or other complications. Role of SGLT2 inhibitors, the drug of the decade. You can see heart failure hospitalization number needed to treat is only 32. CKD progression is 37. MACE reduction is 83, little high. So the benefit has to be transferred to patients if they have these comorbidities by using. And the clinical trials with high and moderate evidence has been given by the side. GLP-1s, we are starting to get GLP-1 into our Sri Lanka. So better to be aware of its applications, its benefit. Semaglutide has not been entered market, but awaiting soon. So these are the benefits with high evidence from several landmark clinical trials on the MACE outcomes and the CKD outcomes. But still, the things that we routinely use, sulfonylureas, TSDs, DP4, they do have a place in a particular patient, especially in the low resource or restrained resource setting. Now, this slide summarizes a lot. When it comes to MACE reduction, how the newer agents perform. When it comes to heart failure hospitalization, you can see the glitazones have been harmful. When it comes to CKD progression and all-cause mortality, how still SGLT2 inhibitors occupy the hot seat. So these are the few cases that he's a newly diagnosed obese patient with no complications. His target has to be less than 7, target in range in the continuous glucose monitoring. So in our setting, it is a metformin, but better if you can use GLP-1. But we expect the weight reduction, that's why GLP-1 will do better. And monitoring with the liver enzymes later on if you are still on GLP-1s. Second patient with established diabetes with a renal involvement with albuminuria significant. His again the primary therapy is SGLT2/1, but with the addition of GLP agonist later. A patient with a multimorbidity and polypharmacy. What matters here is not the target being less than 7. It has to be 7.5 to 8.5. Target in range has to be more than 50, not more than 70. And you have to think about the de-intensifying. So what are the future directions? Future directions are MASH is going to be more and more prevalent among diabetes. So you have to think about the drugs which is known to reduce MASH. Cognitive protection, because the patient's life expectancy is getting higher. Dementia is getting more problem. So you have to think about drugs which has effect on cognition. So dual therapies and sarcopenia prevention. With elderly being more in the society, less active, sarcopenia becoming a problem. So when you give medications, that also has to be seen. Now precision medicine, we are in an era where we learn medicine through anatomy, biochemistry, physiology. But in another couple of decades' time, it will be precision medicine, where they will learn medicine with genomics, proteomics, metabolomics, transcriptomics, and so on and so forth. So anatomy, biochemistry hopefully will be replaced by this mix. And they will identify patients' genotype, their response to therapies, and AI will help us to direct which therapy to be used in which patient. So that is precision medicine. So this is how the 5 subtypes of patients with type 2 diabetes are treated, should be treated. If you use individualized approach from the SED, SID and all, they are not treated all with metformin, all with sulfonylurea, all with SGLT2 inhibitors. So individualized therapy should go beyond medications. Adherence, access and cost strategies has to be borne in mind. And diabetes distress is something that you need to worry about, you as a caregiver as well. So this is a 10-point practice checklist list. Initial assessment, re-stratify, establish individualized therapy, identify the phenotype, it is a SID-SID. Even if you do not name it, at least keep that in mind. This patient is very likely to be insulin deficient one. This is going to be insulin resistant one. Therefore, the particular drug has to be justified. So, sorry about going the last minute. It's a individualized glycemic target based on the patient characteristics and comorbidities and the hypoglycemia risk. And integrate TIR metrics, target in range metrics, along with HbA1c, because we are going to experience continuous glucose monitoring at least in suitable patients. Consider de-intensification. Even though type 2 diabetes is a progressive disease, it does not matter that you have to keep on going up and up and up. Thank you.
Thank you, Professor Veeraratna, for that elaborative lecture. So we are going to move to the second talk today. So it's going to be on obesity, the weight of the epidemic. Will be delivered by Dr. David Chaksha, Assistant Professor of Medicine, Mayo Clinic, Alex School of Medicine, Consultant, Divisions of Gastroenterology and Hepatology, and Transplant Center, Mayo Clinic, Arizona. I cordially invite Dr. David to deliver his talk. Over to you.
Thank you so much for this invitation to speak today. I've really enjoyed the conference so far. This is my first visit to Sri Lanka, and it's been just an amazing experience. So thank you all. I'll be talking on obesity today. I have no relevant disclosures and just a few learning objectives. We'll demonstrate how obesity impacts the healthcare system. We will identify how obesity affects different organ systems and demonstrate understanding of the need for individualized treatment of obesity. So let's just start with a definition. Obesity is a chronic, relapsing, multifactorial disease characterized by abnormal or excessive adipose tissue accumulation that may impair health and significantly increase disease risks. Obesity is diagnosed in adults when body mass index exceeds 30, but there are different cutoffs in Asian populations. I've put the classification system here for overweight, class 1, 2, and 3 obesity. So how does obesity impact the healthcare system? When we look at the global burden of disease, over 650 million people are affected by obesity. Depending on BMI cutoff, obesity prevalence here in Colombo is anywhere from 15 to 30%. And about 0.7 to 2.8% of global healthcare expenditures are related to obesity care, which equate to about 2.4% of the gross domestic product for any one country. For each 5 kilogram per meter squared increase in BMI above 25, the overall mortality increases by 30%. And when BMI exceeds 40, life expectancy is reduced by up to 10 years. So this is a major issue. And I think we've seen that today. Many of the talks have touched on obesity in some way. So let's identify the impact of obesity on different organ systems. And what I think is pretty stark is that I'll really be touching on pretty much every organ system of the body. So starting head to toe, neurologically, obesity causes neuroinflammation, which can lead to structural brain changes, including reduced gray and white matter. So this can lead to cognitive impairment and increased risk of neurodegenerative diseases. From a cardiovascular standpoint, lipid accumulation and vascular inflammation lead to atherosclerosis and coronary artery disease, increase the risks of thromboembolism, valvular heart disease, and as we just recently heard, we increase the risk of heart failure. From a pulmonary perspective, excess adipose tissue restricts to diaphragmatic movement and increases pleural pressures, leading to reduced lung volumes, ventilation perfusion mismatch, and hypoxemia. This can cause the conditions of obesity hypoventilation syndrome, which also results in hypercapnia, obstructive sleep apnea, and pulmonary hypertension. What about the gastrointestinal effects? I'm a hepatologist, so this is something that I encounter frequently in my clinics, but obesity can increase the risk for gastroesophageal reflux disease. It's actually been associated with abdominal pain in general, and visceral hypersensitivity can lead to erosive gastritis. It's been associated with chronic diarrhea and diverticular disease, increases the risk of colon cancer and pre-malignant lesions such as adenomas. Has been associated with pancreatitis, cholelithiasis, and the near and dear to my heart condition of metabolic dysfunction-associated steatotic liver disease, which we'll actually be talking about tomorrow in detail in one of the masterclass sessions. The genitourinary system is not spared. With each 5-unit increase in BMI, the risk of urinary incontinence increases by 20 to 70% in women. Overactive bladder and nocturia are increased, which impair quality of life. We increase the risk of chronic kidney disease with obesity, nephrolithiasis, BPH, and also sexual dysfunction. The endocrine system, as we just heard, is intimately tied to obesity. Obesity increases insulin resistance, thus increasing the risk of diabetes, can cause thyroid dysfunction, gonadal dysfunction, which can cause low testosterone in men and hyperandrogenism in women, as we heard as well, increasing the risk of PCOS. One of the most common effects is the musculoskeletal system. So osteoarthritis is the most common complication of obesity, affecting 91% of patients. And this leads to impaired mobility and independence, which of course limits the ability to treat the disease through activity. The last system I'll talk about is the dermatologic system. There's an increased prevalence of skin tags, acanthosis nigricans, psoriasis, hidradenitis. Can lead to poor wound healing, lymphedema, and lipedema, or collection of fat in the subcutaneous tissues. Basically, the entire body is affected negatively by obesity, which is why it is such a huge problem and accounts for so many health expenditures. So I hope I have explained why the disease is something we need to address. The question is, how do we do this in a condition that is, as I stated, chronic, relapsing, and our body is actively fighting once it occurs? Well, to answer that question, we need to ask the question of why is it so difficult to treat? And the problem is, again, it hits basically every organ system. I won't go through this diagram in detail, but basically from a societal perspective, food is a social activity. Food is also an industry, so there's a push to sell food that is cheaper, less nutrient dense, but also more palatable, which increases the drive to eat more and consume more calories. There is decreased energy expenditure. We just overall move less. And then once obesity occurs, our body establishes new set points, which make it difficult to lose weight, or if weight loss occurs, to maintain it. In other words, our body is actively fighting the measures we are using to treat the condition. The mechanisms for why weight gain occurs can really be divided into four categories. One is hedonic eating. So we eat because it's part of society. We eat because we're happy. We eat because we're sad. We eat because we're stressed. And we take in more and more calories. The other ideas are that there may be physiologic impairment in our hunger signals. So it may, in some individuals, take more energy or more calories to actually feel full. And then there may be patients that don't stay full as long, so they need to eat more frequently. These have all been investigated as some of the underlying mechanisms. Lastly is just general reduced energy expenditure. So some people burn more energy at rest than others, and those that burn less energy are more prone to obesity. At the mainstay of treatment, or at the heart of treatment, there really needs to be a calorie deficit. So they've looked at different dietary compositions of nutrition plans to induce weight loss, and by and large, they all kind of come out the same. It's really a reduction in the amount of nutrients that are taken in. And low energy diets, anywhere from 800 to 1800 calories per day, or an energy deficit of about 500 to 750 calories per day is thought necessary to induce weight loss. The problem is we can't rely on patients to report that to us, as a study showed that patients underestimate their caloric intake by anywhere from 30 to 50%. And with any given nutrition plan, there's about a 20% dropout rate. So it's a very difficult treatment to introduce, to monitor, and to adhere to. There are dietary plans, so prepared meals or portion-controlled meals, but the problem with these is that these interventions are very expensive and not available to all patients. As I said, it's really more about calorie deficit than nutrient or dietary composition. They've compared low-fat and low-carbohydrate diets. Initially, a low-carbohydrate diet may result in more weight loss up front, but when compared over a year, both low-fat and low-carbohydrate diets have about the same amount of weight loss. Evidence would support that there's more weight loss with the Mediterranean diet, however. Another option is time-restricted eating or intermittent fasting, and this is a positive for some patients who like this type of plan, but ultimately it seems to be effective because it too results in a calorie deficit. Now, I've spent a lot of time talking about nutrition and inducing a calorie deficit. One way to do that as well is through exercise to actually burn more calories, but it's extremely difficult to burn as many calories to account for the excess that are taken in. And I give the example that a muffin has anywhere from 400 to 800 calories, and to burn just one muffin on the treadmill, you'd probably have to run for about 30 to 45 minutes, which is just not feasible for most patients. So with the current available therapy, so with dietary modifications or exercise and dietary modifications, lifestyle modifications, what is the efficacy of treatment? Unfortunately, not very good. Only 1 in 10 patients achieve greater than a 5% weight loss that's sustained, and 1 in 1,667 patients with class 3 obesity, the most severe type with a BMI greater than 40, will achieve a healthy weight based on BMI. So we're fighting an uphill battle. Well, we do have more treatments than just lifestyle modifications, and I've provided you a list of the currently approved treatments. The first 3 you'll see are the GLP-1 agonists, or in the case of tirzepatide, the dual GIP GLP-1 agonist. And these agents have been shown to be quite effective. With the first agent, liraglutide, weight loss is about 5 to 10%. And then with semaglutide and tirzepatide, weight loss can be anywhere from 15 to 20%. The sympathomimetics or stimulants like phentermine also induce about a 5 to 10% total body weight loss. Unfortunately, evidence has shown that they are safe to be used long-term, though product labeling would say to use them for several weeks. Phentermine topiramate is a combination therapy which reduces hunger and increases satiety and accounts for about 10 to 12% total body weight loss. Combination medication of naltrexone and bupropion targets the reward system in the brain and induces about 5 to 7% weight loss. Orlistat is a lipase inhibitor and causes fat malabsorption to induce weight loss. So it has a significant side effect that if you ingest significant amount of fats, you'll lead to, the patient will suffer from steatorrhea. And it can induce about 5 to 7% weight loss. Due to concerns about malabsorption, the American Gastroenterological Association has recommended against the use of orlistat, but it is still an approved weight loss therapy. And then lastly, there are rare genetic causes of obesity, and there is one medication that's specified for that for patients that have MC4R agonist deficiency, and that's setmelanotide. The weight loss with that is variable, but it's a daily injection, again, only for genetically confirmed causes of obesity. So as I stated, there are four main causes of obesity, and we can divide these into phenotypes. So when we look at the cause of obesity, it's basically an energy imbalance. There's either too much intake or not enough expenditure, or both. Now, regarding expenditure, we're really looking at reduced energy expenditure, reduced physical activity, or reduced exercise. With intake, we have multiple areas to look at. So one is our actual drive for hunger, and that can be divided into feelings of fullness and also how long we feel full, so satiation and satiety. And then that emotional eating or hedonic eating. that we eat based on our emotions. And if we look at a population, this was out of the Olmsted County Mayo Clinic, Rochester, published this study. Patients can be divided into 4 different phenotypes. Now, some patients have overlap between the two, and there's a small subset of patients that may have multiple phenotypes, and about 15% are just unknown. But we divide those into the emotional hunger, the hungry brain, where it takes more calories just to feel full, hungry gut, where we don't feel full as long, and then the slow burn phenotype is the reduced energy expenditure. Well, being able to identify these specific phenotypes allows us to target specific therapies. And so I provide a schematic here. I think it might appear quite small on the screen, so I'll walk you through it. But we can actually phenotype patients, and we can do it in a scientific manner. For hedonic eating, for instance, which is in the darker green, we actually administer surveys to the patient to look at whether they have a high incidence of anxiety or depression. And if they score high on that, they meet criteria for abnormal hedonic eating. And it's been shown that medications that suppress the reward centers are more effective in these patients. To evaluate for abnormal satiety, or that hungry gut phenotype, the original studies looked at gastric emptying times and rapid gastric emptying, as well as actual patients' feelings of fullness helped to rule that condition in. And for hungry gut, where people are feeling hungry more often, the GLP-1s, which slow gastric emptying and promote feelings of fullness for longer periods, are effective in these patients. And I'll show you the data on the next slides, but just to walk through it. The other is the abnormal satiation or hungry brain, where it takes more calories to feel full. And there have been studies that looked at actual intake of calories. So patients were given Ensure and asked to measure their feelings of fullness. And what they found is that both in patients that had obesity, they had both an increased volume that was required to feel full, and thus a resultant increase in the number of calories. And for patients that have that hungry brain phenotype, phentermine topiramate has been shown to be effective. Now, for patients that have low resting energy expenditure measured, those are the patients that you really do want to focus on exercise to really induce that calorie deficit, in addition to a calorie-restricted diet. So if we're able to phenotype patients, and I went through the data that is available in terms of the specific tests that allowed for phenotyping, this ultimately led to the development of a commercial product that's available, and patients can actually be sent a kit, and they do a swab on their cheek and send the kit back in, and it will give them a report of which phenotype that they fit into. This is not, I did check before I came, unfortunately not currently available here in Sri Lanka, but the manufacturer is expanding globally, and so it is available in several countries, and hopefully will be available in several more in the near future. But if we target treatment, medical treatment, based on patient-specific phenotypes, we actually have an increased chance of success of treating their obesity. And so the bar in red shows what weight loss was at 12 months for patients undergoing just standard of care. So they were meeting with their clinician. It was recommended that they lose weight through lifestyle modifications. They were put on medications based on their clinician. And those patients did have weight loss. About 75% of them lost greater than 5%, but only about 8% lost greater than 20%. And this was looked at over a year, and at about 12 months, they were just shy of about 10% total body weight loss, which is a good endpoint for some things. Like it's good to reduce the inflammation, for instance, in fatty liver, but it's not enough to reverse fibrosis if it's occurred. So some patients need significantly more weight loss. Now, in the phenotyped patients, 98% of them were able to achieve greater than 5% weight loss, and 30% were able to achieve greater than 20%. So a quite significant improvement over the patients that just underwent standard of care. And this was sustained over 12 months of follow-up, with patients maintaining about 15% or greater total body weight loss. When medication and lifestyle interventions aren't enough, there's still a role for surgical therapy. So bariatric surgery still remains an important concept. There's also the emerging role of bariatric endoscopic treatments, where gastric sleeve, for instance, can be done with endoscopic suturing. The most effective treatment is the Roux-en-Y, which accounts for about 31% total body weight loss. Sleeve gastrectomy follows that at about 25%. And then endoscopic therapies are about on par with maximal medical therapy, like the GLP-1s, about 10 to 18% total body weight loss. So why do we care about this, and why do we care about treating it? Well, weight loss improves health and well-being. All of those organ systems improve with weight loss. It improves brain age, lung function, GI symptoms, GU symptoms, and basically overall quality of life. In the last couple seconds here, I'll just say we shouldn't rely totally on BMI. As we heard, there are instances where you can still be metabolically healthy and have an elevated BMI, and that's where other measures of obesity come into play, such as fat mass index and waist to hip ratio. And with that, I will say really what we need to be doing to effectively treat this is to prevent it. So we need population health system-based interventions, such as reducing access to sweetened beverages, focusing on healthy nutrition, focusing on nutrient-dense foods, and the like. So in summary, obesity is a chronic and relapsing disease which affects every organ system. Weight loss is incredibly difficult to achieve and maintain, but can reverse the deleterious effects of obesity, and precision pharmacotherapy, in addition to lifestyle modification, is beneficial in controlling this. Thank you.
The next topic is advancing reperfusion strategies in stroke beyond conventional window. Dr. Tamra Ranasinghe, MBBS, FHA, Program Director, Vascular Neurology Fellowship, Assistant Professor, Department of Neurology, Division of Cerebrovascular Disease, Mayo Clinic, Arizona.
Thank you for the kind introduction. Thank you to Dr. Jayasekar and the organizing committee for inviting me to be here. David, after listening to your story, I think I have to give up eating muffins, right? All right, so I'll be talking about advancing reperfusion strategies in acute ischemic stroke beyond the conventional window. I'll briefly mention about one trial that I've got some NIH funding, the MOSE trial. So the overview for the topic today is going to be, I'll talk about the AHA-ASA guidelines of how to really treat patients who's having acute ischemic stroke. I'll put it into context with a clinical case, and then we'll work together reviewing the emerging data. How do we advance beyond the conventional window, looking at the tissue window? All right, so it was Hippocrates in 400 BC who first recognized stroke. He called it apoplexy because he saw people falling down or all of a sudden not having weakness on one particular side or the other, unable to talk. Later on, only in the 1600, that it was identified apoplexy is something going on in the brain, and then on autopsies, and then figured out there is bleeding in the brain or clotting in the brain. So in 1689, stroke, the word stroke was denoted just to refer to apoplexy, and that's why we call it a stroke. For historical purposes, what was going on at that time in Sri Lanka, it was King Vimala Dhammasuri II who was reigning in Kandy, while the Dutch was colonizing in our coastal areas. All right, now let's look at the population based prevalence in the urban areas in Sri Lanka. Stroke is about 1%, and this has been validated with the Global Burden of Disease study in 2021 as well, to be about 1%. Unfortunately, the burden is much further higher in the US. About 40 seconds, every 40 seconds, someone's having a stroke. And every 4 minutes, someone's dying because of a stroke. And that's why it's important that we reperfuse these patients as soon as possible. Studies tell us every minute that goes by without reperfusion, the patient is losing 1.9 million neurons. So that's why timely effect is important. What are the reperfusion therapies that we currently do is medical management is going to be IV thrombolytics, whether it's TPA or TNK, then endovascular therapy with mechanical thrombectomy. All right, so let's look at the evolution and the advances of reperfusion therapies. Prior to 1995, the medical community used to make fun of the stroke neurologists because we didn't really have anything to do except sprinkle some aspirin, right? So they used to say diagnose and adios because we didn't have any treatment. Later on in 1995, the NINDS trial came out, which demonstrated that giving TPA up to 3 hours, there was a benefit in functional outcome at 90 days. After that, there were several trials that didn't show any benefit. We tried to increase the time, the changing the doses. Nothing really came about until 2008, when the ECAS trial demonstrated benefit, giving TNK or TPA up to 4.5 hours. This is a time that we realized that we have to change the time window perhaps to a tissue window. And that's when 2018, the Wake Up trial demonstrated if a patient wakes up with stroke-like symptoms or not knowing when last seen normal was, but within the last 24 hours, if you can get an MRI brain, depending on if there's salvageable brain tissue, these patients are going to benefit. Moving on to endovascular therapy, 2015, there were 5 trials that came out demonstrating benefit up to 6 to 12 hours of doing from last seen normal. Then the pivotal trials, 2 trials, DAWN and Diffuse 3 came out in 2018, which really changed the paradigm of stroke therapy, up to 24 hours doing thrombectomy. And that's when the 2019 guidelines came up, telling us, including all of this data, and this is what we use as our current standard of practice. I'm going to talk about a few trials. When we talk about stroke trials, our typical primary endpoint is going to be 90 days modified ranking scale. So modified ranking scale is functional outcome. We look from 0 to 6. 0 is no symptoms at all. 6 is death. Typically, functional independence is considered from 0 to 2. A good outcome is considered 0 to 1, MRS. All right, so these are the 2 trials. The first one was the NINDS trial that came out in 1995. Which is in our guidelines. The ECAS trial came out in 2008. So the NINDS trial, the number needed to treat is 8, and within 3 hours of giving TPA. And for the ECAS 3 trial, number needed to treat is 14. Moving on, the Wake Up trial, what they did was these patients, as soon as they came to the ED, we were able to get MRI brain scans. If you see patient A, if you see on DWI, there is a restricted diffusion in the right basal ganglia. Corresponding there on the FLAIR images, there is no hyperintensity. So there is a mismatch, telling us these are the patients that perhaps this is salvageable tissue that we can really save. If you look at patient C, the left caudate, we see the restricted diffusion on DWI. And when we look at FLAIR, there is a corresponding hyperintensity, telling perhaps these are the patients, there is nothing that we can do at that particular time. So patient A and B were the patients that were included in the trial. And what did it show? This is an MRS graph that we discussed before. If you look at the top arm, the alteplase arm, there are more patients in the MRS of 0, 1, and 2 compared to the bottom, which is the placebo, which has less patients, telling us there was an increase in functional outcomes in the patients who were getting TPA. What is the difference between TPA and TNK? So TPA is a recombinant version of our endogenous TPA, whereas TNK is a bioengineered. There's a difference in the dosing as well. TPA, a bolus needs to be given, 10% is bolus, and then the rest is given in infusion over 1 hour. Whereas TNK, it's a bolus that we give. And majority of the hospitals in the US moved to TNK because, especially during COVID, to decrease the interface between the patient encounter, that was one major reason that moved away. But apart from that, you see on the right, the table, there are several trials that had demonstrated non-inferiority when we compare TPA to TNK. And also we have to remember TNK is more fibrin specific, more resistant to more resistant to degradation, and TNK also has a longer half-life. TNK half-life is about 24 minutes, whereas TPA is anywhere from 3 to 5 minutes. All right, so what are the inclusion criteria to give IV thrombolytics? So you should suspect the patient is having acute stroke with disabling symptoms, and the patient should be within 4.5 hours or up to 24 hours if it's a wake up. What are the exclusion criteria? That you should not see bleeding in the brain or has a history of bleeding. Or if on the CT scan, if you already see a large hypodense area telling the patient is having a large stroke, these patients are going to be at a higher risk of bleeding. So these patients should be excluded from giving IV thrombolytics. Blood pressure is very, very important. We have to bring down the blood pressure. Blood pressure should be less than 185 over 110. And serum glucose, if it's less than 50, it is contraindicated because initially you have to give some dextrose to see is this hypoglycemia typically causing this lateralizing symptoms or not. Moving on, if the patient has had prior bleeding, recent bleeding within 24 hours, or active bleeding, if the patient has any surgeries, mainly if it's intracranial or spinal surgeries, or if they've had a stroke within the last 3 months. Moving on, if they've had severe trauma within the last 3 months, or if they have a brain, if you know there's a neoplasm in the brain, or structural GI malignancy. Also, if you suspect the patient is having a stroke because of infective endocarditis or because of aortic arch dissection, we should not give TPA for these patients. What if the patient is on warfarin? These are the patients that we have to wait till the INR comes down. The INR should be less than 1.7. If the patient is on direct-acting oral anticoagulation and they've taken it within the last 48 hours, we should not give IV thrombolytics at this time. And also platelet count should be greater than 100,000. All right, so moving on to endovascular therapy. So these were the two pivotal trials, DAWN and DIFFUSE, which demonstrated the benefit, right? If you look at the MRS graphs at the bottom, you see the thrombectomy arm on top and the control arm at the bottom there. If you see, there are more patients in the MRS of 0, 1, and 2 in both the studies. So these two studies were beneficial for our patients. And who are these patients who are going to really benefit with mechanical thrombectomy? So for that, patients need to have disabling symptoms. And what are really disabling symptoms and how do we really identify? We do an NIH stroke scale. This is a scale that goes from 0 to 42. 0 means no symptoms at all. Greater than 6 is considered patient is having disabling symptoms. And on CTA, they need to have a large vessel occlusion. And what do I mean by a large vessel occlusion? A clot anywhere in the ICA in the neck or in the brain, or M1 segment middle cerebral artery clot. Then moving on, they have to have salvageable brain. And what do I mean by salvageable brain? It's also called penumbra. So let's look at this illustration on the right top. So what you see in red is the core. At that given moment, the clot is causing an infarct in that area, and that is irreversible tissue. Unfortunately, you cannot do anything about it. And what is in yellow is the area what we call salvageable brain or penumbra. So at that given point, because of collateral supply, that area is currently not infarcted. What happens is if we don't do anything, the red becomes the whole of yellow and the infarct size increases. How do we look at this as a surrogate marker? Once we do a CTA, we get a CT perfusion scan. And the perfusion scans, we look at cerebral blood flow and Tmax. And what is Tmax? Tmax is the time that is taken for the contrast to get to the brain. We compare the left to the right or right to the left. And once the perfusion is done, there are several softwares that are really good. We use Rapid software. That spits out this perfusion map, what you see at the bottom. So that one, if you see what is in maroon, is the area what we call the core. At that given point, we cannot do, unfortunately, anything for that area. But what is in green is the area at risk. So the purple minus the green, if you see, that is, purple is, if you see at the bottom, you see 5 cc's or 5 ml. And on the green, the Tmax is 114. So 114 minus 5 is 109, which is penumbra salvageable tissue. At that given moment, if you can reperfuse this patient, you're going to save 109 cc's of brain tissue. So what did Dawn and Diffuse trials, what type of patients did they include, and what is the perfusion criteria? This is the perfusion criteria that we go by. The core has to be less than 70. So what the purple area has to be less than 70. The penumbra, the area that you can save, should be at least 15 cc's. And the mismatch ratio between the two should be greater than 1.8. So this patient that we just looked at the perfusion scans would have been an ideal patient for thrombectomy. All right, let's put this into perspective, right? So number needed to treat for thrombectomy is 2.7. If you give antibiotics for a patient who's having UTI, for symptom improvement number needed to treat is 2 to 4. For over-the-counter, for headache medications, number needed to treat is about 9. And if someone's having a STEMI and you do a PCI, number needed to treat is, for avoid major adverse cardiovascular events, is about 10. The reason why I put this is for us as a medical community to think about endovascular therapy, not only in stroke, it is a game changer in whole of medicine. All right, so let's look at a case. A 67-year-old female presents with right gaze preference and left hemiplegia. Last seen normal was 4 hours ago. Blood pressure was 178/90, serum glucose was 108, NIH stroke scale is 16. So telling us disabling symptoms, the patient, the first thing that we do is we get a head CT because we want to rule out, we want to see if there's bleeding in the brain or not, right? So there's no bleeding in the brain, so we are concerned this could be a stroke, ischemic stroke. And what do we really do? Patient did not have any contraindications for IV thrombolytics, so we go ahead, this patient got TNK. While we give TNK, with the CT scan, we get a CTA and a CTP as well. When we look at the CTA, we see the coronal images over here where the red arrow is, there is a clot sitting there in the right M1. All right, get the perfusion. So this is the perfusion scans that we just discussed. So this is a patient that we can save a lot of brain. So patient gets thrombolytics and goes for endovascular therapy. And when the patient's taken for endovascular therapy, so this is a cerebral angiogram, you can see the AP view. You can see the clot sitting in the right M1 on the right, and the left is open. So the right should actually look like the left, right? And then the clot is retrieved, and the patient reaches TK2B reperfusion. And what do I mean by TK2B reperfusion? I would say we are about 10 years behind our cardiology colleagues. Cardiology uses a TIMI score, so we've copied off them. It's called the TIKI score, which tells us how effective was our reperfusion. So it's a score from 0 to 3. 2 is divided into 3, 2A, 2B, and 2C. 2B is considered greater than 50% reperfusion, and 2B, 2C, and 3 is typically considered successful reperfusion. And how do you remember it? The easiest way is to be or not to be. All right, so the next day we get an MRI scan for this patient. The patient does end up having the stroke that you see on the MRI scan. And it is similar to the core that we saw initially. So this tells us this was a good outcome. A patient who came in with pelagic completely on one particular side at day 3 went into acute rehab. All right, so let's now peek into what is there beyond the window of current standard of care. So 2019, the EXTEND trial came out demonstrating that perhaps up to 9 hours, if you have enough salvageable brain, we can give TPA for these patients. Earlier this year, the HOPE trial demonstrated up to 4.5 hours to 24 hours. Again, if there's salvageable brain, giving TPA was safe, and functionally, the patients had a good outcome. I spoke about anterior circulation. What about posterior circulation? The ATTENTION and the BEOS trial looked at the basilar artery occlusions, and there was a benefit in doing thrombectomy up to 24 hours for these patients. And over the last 2 years, there have been 6 trials that have come out, which have demonstrated even if the patient has a large core, there is a benefit in doing thrombectomy for these patients. So I'll be talking about these 2 trials just for time's sake. All right, so the HOPE trial just came out from China this year. They randomized 372 patients, and they looked at the salvageable brain, if we could really look at the tissue window rather than looking at the time window. So the core had to be less than 70 cc's, the penumbra salvageable brain had to be greater than 10 cc's, and the ratio should be greater than 1.2. Just keep in mind, this is not endovascular therapy, this is still giving IV thrombolytics. And what did they say? 40% of the patients who got TPA had a good functional outcome compared to 26. And also, if you see, there was an increase in risk of bleeding. If you look at symptomatic ICH, 3.8 versus 0.51. So that tells us, and that was significant. However, if you look at the NINDS trial and the ECAS-3 trial, both of those trials, there was an increase in risk of bleeding. But we still think the benefit outweighs the risk. And when you look at the mortality, because remember MRS6 is death, the mortality was the same in both the arms. All right, so moving on to large core, what do I mean by a large core? So if you see, do you remember the previous patient had the purple area was like 5 cc's. This patient, you see the purple area is 100 cc's. So this patient's having a large stroke. And also there is a surrogate mark on the head CT. We look at the head CT, there's a score called the aspect score. I won't really go into detail about it for now. Tomorrow at the master classes, I'll be going through that. Aspect score can be also used. If it's less than 6, we consider this as a large core stroke. And these were the 6 trials that came out. And if you look at it, this is a forest plot demonstrating there was a benefit in carefully selected patients. And moving forward, what can we do is, if the patient, especially younger patients, and their functional baseline to begin with prior to the stroke is very good, MRS of 0 or 1, they're having disabling strokes. On a CTA, they have a large vessel occlusion, and on aspects 3 to 5, which is considered large core, and presenting within the 6 hours, you can extend to 12 hours, there is a benefit in getting thrombectomy for these patients. However, this is currently not our guidelines. It is not our standard of care right now. All right, so if moving forward, is there any other additional medications that we can do apart from TPA, right? Bridging therapy. The most trial, so this was a randomized trial, which after patients who got TPA, these patients were given either one arm was argatroban. So argatroban is a direct acting thrombin inhibitor. Eptifibatide is a 2B3A inhibitor, it's an antiplatelet, and a placebo. So 514 patients were enrolled. Unfortunately, the study was stopped for futility because mainly the argatroban arm, there was increase in risk of mortality. And this was a very dear study for us because we were one of the highest enrolling sites in the country. SLCIM trial, which just came out 2 months ago from China. What they did was something similar, but instead of eptifibatide, they use tirofiban. So tirofiban has a much shorter half-life. It's also known as agrostat. The patients who got tirofiban after TPA, there was a benefit. 65.9 patients had a good functional outcome compared to 54.9. Keep in mind the 2 trials. The first trial, the most trial, we did enroll patients who underwent endovascular therapy as well. But as at IT trial, they did not enroll patients who underwent endovascular therapy. How about expanding the window? We were talking about large vessels. How about medium-sized vessels? So what is meant by medium-sized vessels? M2 to M4, A1 to A3, P1 to P3. When we look at the 3 trials that came out earlier this year, there was no benefit in doing endovascular for these patients. Is it the end of the road or just a detour? I think, with better patient selection, we can do a better job. How about additional therapy? Patients who get good, successful reperfusion, giving IA TPA. So think about it. These patients get IV TPA, thrombectomy, and locally getting IA TPA. So the Catalonia group from Spain demonstrated there was a benefit. This was published in 2022. The Pearl trial, which just came out last month from China, demonstrated there was something similar, that there was a benefit. So overall, perhaps there is a future in thinking about IA TPA. Let's quickly go through this to summarize the reperfusion therapies that what I discussed. If a patient comes in within less than 4.5 hours, standard of care, give IV thrombolysis, get a CTA. If there's a large vessel occlusion with salvageable brain tissue, endovascular therapy. If there's a large core, you can consider endovascular therapy. However, if patient wakes up with stroke-like symptoms or within the last 4.5 to 24 hours, if there's a large vessel occlusion, thrombectomy. No large vessel occlusion, get a stat MRI brain. If there is a DWI flare mismatch, you can give thrombolytics. Also, you can use perfusions to give thrombolytics as well. I would like to end by this. I've been here for now the time says almost 25 minutes. So over the last 25 minutes, 37 people have had a stroke and 6 have died because of a stroke, if you look at the US data. So that tells us we have to do a much better job in our treatment. Thank you for your time.
Thank you, Dr. Ransing, for that very comprehensive talk. With the interest of time, now the forum is open for discussion, but I'm sorry, we can entertain only one question. So if there is one burning question, we can give opportunity for you to ask. Right. In the absence of questions, just one question to Dr. David. Yeah. What's your understanding, or what do you think about this so-called healthy obese?
Sorry. In regards to healthy obesity, I think that it's really a matter of what we're trying to treat. So I hope, during my talk, I mentioned that obesity affects just about every organ system. And I think when we talk a lot about healthy obesity, we're focusing on risk factors for metabolic syndrome. But I think that it may not target the other aspects of obesity. So I still would have significant concerns that obesity represents a disease process. And I think I would be worried about the health-related quality of life in those patients.
Thank you. I know the trainees especially might have quite a lot of questions to ask from Dr. Ransing, but then I think during the tea time, if you can meet and ask questions. So we will wind up this session. I would like to invite Dr. KVC Janaka to hand over the tokens of appreciation, the certificates of appreciation. First to Pastor Tilak Veeraratna. Dr. David Chaksha. And Dr. Tamra Ransing. Thank you very much. Thank you very much for your participation. So we will close this session.